So as Casey said, my name is T, and as she introduced me yesterday, I'm treatment burden guy. So I will talk to you about treatment burden. I'm a researcher in Paris, so this is the Isle of the City in Paris, and just approximately all. So I've been working on the burden of treatment for, I think, about 7 years, and this work began with two very different facts. The first one that we had the chance to attend one of Victor's conference where he called for research on minimally disruptive medicine, so we thought, yes, that's a good idea, let's do that. And the second one is a much more sadder fact, is that a diabetic 9-year-old girl killed herself because her doctor told her, you can't eat candies anymore. And it increased our motivation to work on the burden of treatment. These events were very closely related. So I think Casey has already shown you the wave of chronic conditions. So I'm showing you the wave of chronic conditions. And as she has said, about 50% of patients with above 50 years old have at least one chronic condition, and about 20 to 30% of them have more than one chronic condition. This is the same data presented slightly differently. So here on rows and columns, you can see the 10 most frequent conditions in this study. That was UK primary care data. And here, the dots, you see the association between these studies. That is 52% of patients who had coronary heart disease also had hypertension, and 18% of patients who had hypertension also had coronary heart disease. So you can see that there are clusters of conditions. Of course, there are clusters of cardiovascular conditions, but there is also a small cluster here of pain and depression. What is more interesting, or what is interesting also, is this column here, which shows the percentage of patients who have only the row condition. And this number is quite low, which means that when you encounter a patient with one chronic condition, he is very likely to have multiple chronic conditions. And for example, patients over 65 years old who have diabetes have a mean of 6.5 chronic conditions. I think it's here. So before I go further, I want just to define the workload of care. The workload of care is the demands in patients' lives for health-related activities. Appointments, doctor visits, drug management, self-monitoring, etc. And this workload of care is quite objective. You can measure it. You can measure the time spent. You can measure the number of visits, the temporal dispersion of visits, the number of pills taken every day, etc. Doctors usually understand the workload of care very well. And I will give you some examples. For example, patients with type 2 diabetes under oral treatment spend approximately 43 minutes per day in mean in self-recommended care. So it's important. It's a mean, so there are days where they spend more time, there are days when they spend less time, but it's a mean of more than 2 hours per day in self-recommended care. It's huge. And it gets worse when patients are multimorbid. I think most of you know this example of a hypothetical 79-year-old woman with COPD, diabetes, hypertension, osteoarthritis, and she would take 12 different medications a day, plus a very complex non-pharmacological regimen. The first medication would be at 7:30 in the morning, the last medication would be at 8 in the evening, and she would have like this very complex regimen like Casey told you this morning. And we can see that part of the problems comes from our siloed approach of medicine, where we think about disease in silos, so the patient is the addition of his different chronic conditions. When we do this, we can obtain things like this. So this is a work from a colleague of ours, Céline Buffet-Duport, who assess the theoretical workload of care, the theoretical time spent in health-related activities, if patients followed every possible guidelines for one chronic condition, two chronic conditions, three chronic conditions, etc., for an association of different chronic conditions. And if you look at the nice blue here, the lower part where patients have three chronic conditions, an association of three chronic conditions, they spend a mean of 30 to 60 hours per month in health-related activities. So I'm not very expert about the US system, but in France you have a legal time requirement of 35 hours of work per week. So having a chronic condition is having three chronic conditions, is approximately equivalent to a part-time job. So it's interesting to note that, and you don't get paid for that. So it's interesting to assess the time spent in health-related activities, but the truth is more complex. But before I go with the truth, I want to show you this awesome picture of my hospital. And why I wanted to show you this picture, because it's very special. It's one of the very rare days where the sky was so gray. Usually it's clear blue and it's gray. I'm part-time travel agent for France. So I'm going to talk to you slightly about the work I performed in sub-Saharan Africa. And our goal was to describe the workload of care for patients with HIV and to assess to what extent this workload of care could be avoided. So we had the population of patients with chronic HIV. That is, we did not want to assess patients who were starting treatment, who were just diagnosed. These were patients who were under antiretroviral therapy for more than 1 year. And we assessed what they were doing using a method derived from sociology. So it's a method called the daily reconstruction method, developed by Daniel Kahneman, who obtained the Nobel Prize, but not for this work, and which was published in Science. And the idea is very simple. He used this method to describe the happiness of people in daily life activities. So he asks people to describe the different activities they are doing in the day, like a series of sequences in a movie. And he asks them, so where were you with? I was in my bathroom, I was with my wife began yelling at me, etc. And then for each episode, he asks structured questions. That is, so how happy were you, etc. And using this method, he came up to the conclusion that being with your wife is approximately the same as being with your boss. Interesting conclusion. Read the paper in Science. It's very interesting. So we adapted this method for our work. So what we did is that we did exactly the same thing. We asked patients, tell us about everything you did to care for yourself. And they told us that in very open interviews. And afterwards, for each episode we identified, we asked structured questions about the nature of the episode, the nature of the activity. Was it at home, not at home? Was transportation required? Did he wait before any consultation, visit, test, etc.? How much money did he spend? And what was the opportunity cost? That is, what would have he been doing if he had not been doing that? Okay? So we did that, and we obtained these results. So here, each small line here is a patient, and here you have the time spent in health-related activities. So you can see that it's very heterogeneous. Patients can spend a lot of time or almost no time in health-related activities. What is more interesting is the colors. So you have these reddish colors which represent visits, drug management, physical activities, self-monitoring, and these bluish colors which are waiting rooms and transportations. So we are in sub-Saharan Africa. I had to remind you that, but in sub-Saharan Africa, half of patients' time devoted to healthcare is spent in transportations and waiting rooms. So they spend a lot of time, and half of this time is spent in transportation and waiting rooms. And even more, patients in this setting usually earn not too much money. And for example, 50% of our population earn less than $100 per month. And transportations represent a huge cost for them. So our problem is that two patients can have the same total time spent in healthcare activities, but a complete different workload, because they have a complete different complete different allocation of activities. They have different opportunity costs. They have different monetary costs. So it's not the same. So speaking about the workload of care of patients using total time spent in health-related activities is relatively naive. So we wanted to go further in that, and it was difficult. So then we use the data we have to try to create a single assessment of the workload of care. So we use unsupervised learning methods, and we calculated the distance between patients for 5 variables, features that seemed important to us, which was the nature and time allocated in each health-related activity, the opportunity cost and time associated, the pill burden, that was just the number of pills they took every day, temporal dispersion of activities. It's not the same if you have all your activities grouped on the same day, or if you have the doctor visit on the Monday and the test on the Tuesday and the doctor visits on the Wednesday, etc. The monetary costs, which we related to patients' revenue. And using these 5 variables, we try to discern homogeneous patterns of workload of care in our patient sample. So these results, they seem complex, and they are complex, and that's the main message I want to convey, is that the workload of care is a very complex, multidimensional construct, and you have, it's very heterogeneous, because the sample of patients were globally similar, but their workload could be very different in terms of pills, in terms of temporal dispersion of activities. These patients had no temporal dispersion of activities, and these had huge temporal dispersion of activities. These patients spent a lot of money, these patients did not spend too much money, etc. So there were a lot of features, and then we realized that it was complex. The workload of care of patients was complex. So, okay. The second goal of this study was to assess the theoretical avoidable workload of care. So we had the very simple hypothesis that if patients' visits were grouped, for example, if tests and visits were grouped on 10 days, which is possible, and some patients had already had this kind of schedule feature, then it could decrease the workload of care of patients. So we defined the avoidable workload of care, the resources invested by patients that could be saved if visits and tests were grouped on same days. And we found that 22% of our population, which is in fact 30% of patients who had at least 2 activities not at home, had theoretically avoidable workload of care. And simple adjustments in visits and test schedules could lead to a 20% decrease in health expenditures and time spent in health-related activities for these patients. So just for that is, the workload of care is complex, and I think it's very difficult to discuss the workload of care without relying on very naive and simple summary statistics like the total time spent in health activities or the pill burden, but in fact it's much more complex than that. And patients with the same workload of care can have a different burden of treatment. Patients with different burden of treatment can have the same workload of care. Maybe I'm getting lost, so something like that. And second point, there is a potential for an important reduction in the workload of care for patients with simple adjustments in visit schedules. So, before I move to the burden of treatment, which is technically the important part of this presentation, I want to show you some crocodiles. This is a picture in Africa, of course, and these are crocodiles in Yamoussoukro, the capital of Côte d'Ivoire, because all of you know it's not Abidjan, it's Yamoussoukro. And the story is that these crocodiles are very ferocious animals. For example, there was this guy that used to feed them every day for years, and on one day he slipped, and then he got eaten alive. True story. So now the point. Okay.
Is there a reason for sharing that story?
No. I thought it was interesting.
Somebody's always got it worse than your burden.
Exactly. So the burden of treatment is the impact of the workload of care we have been discussing about on patients' well-being and quality of life. And as you have understood from all presentations from today and from what I have been telling you, is that the workload of care is not at all the same as the burden of treatment. So usually we say, yes, this patient is overburdened, he's under dialysis, or he has this very complex therapy, but it's not true. That is, there are patients with very simple care for us physicians who can have a very important burden of treatment. So there is a huge difference between the workload of care and the burden of treatment, which is related to patients' capacity, etc. And as I wanted to say, if you want to talk about capacity, ask Casey. I am not an expert in this. So the capacity, it's important, ask her. So people wanted me to talk about measuring the burden of treatment. Why? Because as you can see, there are several measurements of the burden of treatment. So there is a measure from Cynthia Boyd, there is a measure from David Eaton, there is of course a treatment burden questionnaire, and I heard that Chris Salisbury, it's not I heard, I reviewed his paper, Chris Salisbury is creating a new measure for the burden of treatment. What you should remember is that Swan et al. Was the first one, and in my very personal opinion, it's the best. So I'm not going to tell you about how to develop and validate patient-reported outcomes, but I'm going to show some results we obtained during the validation of the measurement of the burden of treatment. So, picture. Last year I came to this workshop, and he said, "Hey T, I had this awesome idea. Why don't we compare the physician assessment of the burden of treatment and the patient assessment of the burden of treatment?" And then I had to remind him that we already did it, and that he was a co-author of this paper. Just for you. So this is a Blunt-Altman plot, which is very easy to read. It plots the difference between the patient and the physician scores against their mean. So what does it mean? It means that all dots above this middle line mean that the physician overestimated the burden of treatment. All dots under this middle line means that the physician underestimated the burden of treatment. So you can see there are dots everywhere. It means that physicians have no idea about their burden of treatment. And you can also see that on the intra-class correlation coefficient, that was relatively low. And it's not so low thanks to family doctors, because when we separated family doctors and hospital specialists were the worst, family doctors were not too bad, but not too good, and informal caregivers were better. So this is exactly the same plot with informal caregivers, so informal caregivers underestimating the burden of treatment. And you can see that dots are much more compacted around the central line, and that they had a better estimation of the burden of treatment of patients, but not perfect. This is another result I wanted to show you, so it's unreadable. It shows the cross-country comparison of the burden of treatment scores in different countries. So this is the US, this is United Kingdom, Canada, New Zealand, Australia, and other countries. These were results obtained during the cross-cultural validation in English of the burden of treatment questionnaire. Yes, because our measurement is also available in French, Chinese, English, Spanish, and I think Arabic. It's good. Use it. And, yeah. Yes.
On the last slide, sorry, who comes under informal caregivers?
So,
Click in the middle, just click in the middle of the screen. Click, there you go.
Yes.
Yes.
So we ask patients to select one people that help them in their care. So it could be a family, it could be friends, it could be neighbors, it could be, I don't know what. So they were selected by patients as an informal caregiver.
Okay, thank you.
And in lines here you have the different items of the burden treatment questionnaire. For example, the first one is the taste, shape, size of my tablets. Here you have my doctors don't listen to me, don't take me seriously. Here you have the financial burden of treatment. Here you have the need for my medical healthcare the need for medical healthcare on a regular basis reminds me of my health problems. The main result here is that you can see it's relatively homogeneous between the different countries. That is, here it's light green, here it's more reddish. And the two items here for which people had higher burden of treatment were how does your healthcare impact on your relationships with others, being a burden for others, being embarrassed to take my medications in public, etc. And the need for medical healthcare on a regular basis reminds me of my health problems. There are some differences. For example, patients in the UK think that their doctors don't listen to them seriously. I'm not completely sure about why we obtain this result. Maybe it's because of the UK system of quality outcomes framework. We don't know why we obtain this, but it's a notable difference. So when we were doing this, because we did that in France first, and in France we had this cute result that is French patients don't have a financial burden of treatment. Because as you know, in France, our national insurance system covers 100% charge for patients with chronic conditions. So they don't have to pay for anything, for doctor visits, for medications, etc. So they have only to pay for, I don't know, some transportations, but not medical transportations, etc. So patients in France did not tell us much about the problems of financial burden. And there were some other studies, for example, in Australia, where patients said that transportation were a huge problem. Because in Australia, when you are in the back, the outback, and you have to go 500,000 kilometers to see a doctor, it can be a problem. So we realized that there were differences between countries, and we wanted to investigate these differences between countries in the burden of treatment, in the patient's perspective of the burden of treatment. So we performed a survey with open-ended questions, and 1,053 participants from 34 high-income countries answered. And we had this huge bunch of open-ended text, which I read, and in double with someone else. And we also use automatic natural language processing methods to analyze this data. And that's how we obtained this figure. So this figure are the quotes from patients reorganized from all the different problems they could have, the consequences of these problems, and the factors that aggravated the burden of treatment. I know the figure is very hard to read, and I can't talk about all these things, but I invite you to read the paper or ask me. I have tons of stories from patients from this study. So the problem is now we know the concept of the burden of treatment, we know the concept of minimally disruptive medicine, we know how to measure the burden of treatment, but how do we reduce it? How can we reduce it? So when I prepared my slides, my colleagues told me, don't post this photo, you have dirty feet. So yes, my feet were dirty on that day, but I assure you that they are clean today. So I'm going to talk to you about another study I performed in Africa, and it's a very simple study. It's patients' perspective on how to decrease their burden of treatment. So it's very simple. We had these patients with HIV from the first study, and I asked them a simple single question, which was, what should we change to decrease your burden of treatment? In fact, the question was, what do you believe are the most important things to change in your care to improve your burden of treatment? And patients told us a wide variety of stuff, and we analyzed it similarly to the burden of treatment study I showed you before. Then for each patient proposition, we asked experts to tell us, is it feasible or is it not feasible? Is it feasible at low cost, or are you completely delirious? It would require millions from the Global Fund. And our experts were hospital leaders, policymakers, and of course patients and caregivers. And we obtained this. So I love these figures, you will say, but I think they are nice. So these are patients' propositions to decrease their burden of treatment, and the dot color is the feasibility. Green, easy, red, not easy. And so we had different stuff. For example, here is consultation content. Changing the consultation content, not so difficult. Changing medication plan, sometimes it's difficult, sometimes it's not. Getting the state to reimburse care, difficult. And for people who are interested, here you have some patients who told us, and there was no hint, it was just a single open-ended questions. I want to take part in the decisions of my doctors, etc. So people came up with the shared decision making, and they were, yeah, we need this. We were in Africa, they didn't have mention of shared decision making or anything, but they said it would decrease their burden of treatment. Here we have the expert's opinion and the number of times each proposition was made. And what is interesting, so I can't read. I can't read like that. Well, I don't know where it is, but what is interesting is that for the shared decision-making one, I think the physician said it's not possible. It's not doable. Implementability low. So interesting. What we saw here is that approximately 50% of patients' propositions were green in terms of propositions. So here we have 60 propositions, and approximately we have, yes, and 27 were it could be easily implemented. And 30% of our populations, and slightly more than 30% of our population, thought that quoted something that was easily implementable, and they said it could decrease their burden of treatment. So why is this study important? Because the first thing that struck us was that patients said exactly the same things as patients in other settings. The propositions from patients to decrease their burden of treatment, the problems they had, were the same as those from patients in France, in the US, in the UK, etc. Usually we think of minimally disruptive medicine, of tailored care as features of a high-income country, but in fact it's not. Every patient in the world has the same problems, and we should move to global minimally disruptive medicine. And these kinds of methods can be used to create discussions in care organizations on how to improve care organizations. So this is the blue sky I was talking about. It's not photoshopped at all. And why did I put this picture? It's because here it's our hospital. So this is next to Notre Dame, the best cathedral in the world, and here is our hospital. So what now? And that's my last slide, I think. So what's next? So I told you about the global minimally disruptive medicine. I think it's important. I think now that we know how to measure the burden of treatment, we should stop working too much on measuring the burden of treatment, although there is much work to be done, but we should also work on creating real interventions to reduce the care of patients. And recently, for the last 6 months, our team has been working on reflecting on how new technologies, digital care, can reduce the burden of treatment. So today, everybody says, yes, new technologies can be the solution. But the problem is that it can also be very frightening. It can increase isolation of patients. It can dehumanize medicine. So our idea is to leverage on these technologies to create this care that preserves the humanistic values of the patient and physician relationships. So that's our goal, and we're working on that. Maybe I can tell you in private because it's very secret and confidential. So I will tell you if you want. And of course, we are talking about the burden of treatment, etc. There is also the burden of research, not only for patients, as I can't remember who is talking about that, but there is also a burden of research for researchers. This is a picture of my office in Africa, and here are the patient report forms for our study on the burden of treatment, and you see that there are tons of them. So it's hard work. Okay, and that's all.